Hi, my name is Ajit, and I'm happy to have this opportunity to present one of the components of my ongoing research with South Asian communities in British Columbia. I have a short PowerPoint presentation to share the findings of my research. I would making this presentation under the following headings. I will be presenting the interdisciplinary research design, which was conducted in 4 phases. This slide shows the interdisciplinary research design of this project. In phase 1, we had the quantitative epidemiological component that dealt with the incidence and survival trends of South Asians as compared to the general population. In phase 2, we conducted a qualitative study which provided the social cultural context of the risk behaviors associated with the observed incidence and survival trends. The findings of the qualitative study were used to design educational interventions for South Asians. In phase 4, we conducted an analysis of the ongoing study under BC Oral Cancer Prevention Program. The ultimate goal of this research project is to reduce the incidence and mortality of oral cancers among South Asians in British Columbia. In 2006, 1 in every 6 Canadian was an ethnic minority, but in 2031, 1 in every 3 Canadian will be an ethnic minority, which means 64% population in Toronto, 59% in Vancouver, and 31% in Montreal will belong to an ethnic minority. And if we look at where this immigration is happening, it's mainly happening from the Asian countries like China, India, Pakistan, and Sri Lanka. If we look at the epidemiology of oral cancers, these are the same countries that have the highest rates of oral cancers. Because in China, the prevalence of smoking is very high. And in India and South Asian countries, people are chewing brittle quid and smokeless tobacco. So we have a situation where we have immigration from those countries that have the highest risk of oral cancers. But what we do not know is what is the risk of these immigrants after they have come to Canada as compared to that of the general population. And this led to the phase 1 of our study, in which we wanted to see the incidence and survival rates of South Asians as compared to the general population. We have data from 1980 to 2006 from the BC Cancer Registry. And we use a surname list to determine the ethnicity of the patients. The results of our study suggested that indeed South Asians had higher rates of oral cancers as compared to that of the general population among both men and women. When we looked at the age-specific incidence rate, we found out that in the age group of 65 to 74 years, South Asian men and women had 2 to 3 times higher rate as compared to that of the general population. And as the immigration from these countries are increasing, the number of the cases are also increasing. When we look at the subsites, South Asians have highest cancer rates at the sites like gums and cheeks, whereas in the general population, we found the highest rate was associated with floor of mouth. And this actually provided a strong evidence that brittle quid and smokeless tobacco may be responsible for these observed rates because we know from the epidemiological studies that chewing brittle quid and smokeless tobacco leads to higher rates of oral cancers and gums and cheeks. When we look at the survival rates, we found that the South Asians have poorer survival rates as compared to the Chinese and the general population in both men and women. Therefore, from the phase 1 of our study, we found that South Asians have the highest rates. These numbers are increasing as immigration are increasing. And these cancers are seen mainly at the sites associated with chewing brittle quid and smokeless tobacco, and they have the poorest survival rates. In the phase 2 of this study, we'll be trying to understand the social cultural context of behaviors which may be responsible for these observed incidence rates. Thank you.